Hi, I'm Dr. Scott Werden, the TOS guy. Today we have a talk sponsored by us featuring me. I'm going to talk about why MRI is the best choice for diagnosing TOS. Let's switch to our presentation mode. And away we go. Why is MRI the best test for diagnosing TOS? Let's review a couple quick things about TOS itself. Thoracic Outlet Syndrome occurs when there is symptomatic compression of the arteries, the nerves, or the veins that pass through either thoracic outlet. There are three types of TOS because there are three structures that pass through each thoracic outlet. There is arterial TOS, there's venous TOS, and there's neurogenic TOS. Neurogenic TOS accounts for about 95% of all TOS cases, and it is the type that is the most difficult to diagnose by far. Most cases of neurogenic TOS, or TOS in general, have compression of multiple structures, and along each structure there can be multiple points of compression. Let's keep in mind that many different types of TOS have been described over 200 years in the literature. It's not a homogeneous disease, so we have to be prepared for a lot of complexity. Now, the clinical diagnosis of TOS, that's when your doctor examines you in his or her office, it's quite challenging. You may have heard of clinical tests that include Adson's test, the Wright test, Halstead maneuver, ruse test, etc. All of these have been shown to be pretty so-so. They're not excellent, they're not specific, they're not sensitive. There are many different patients that have many different of these tests that are positive. Maybe some of them aren't positive. So when we say the last point, these tests are known to have limited sensitivity and specificity. Those are just medical research words that say they miss some cases or they overcall some cases that aren't really there. So the clinical examination should be a starting point. It should not be the be-all and end-all. Let me also remind you, as I tell other people, I tell a lot of my doctors, that the MRI isn't by itself, or any diagnostic test, isn't by itself meant to replace the clinical examination. It's meant to work with the clinical examination. So your doc suspects you might have TOS, get you the right kind of imaging. And besides diagnosing TOS, the right kind of imaging can show which type you have. I've recorded 25 or 26 different types in the literature before 1956, where a neurology fellow said, I'm going to take all this complexity and boil it down and just call it one disease, Thoracic Outlet Syndrome. His name was Pete, P-E-E-T, that's his last name. And his paper states there's all kinds of cases, there's all kinds of complexities, there's all kinds of causes. So let's just call it one disease. I believe, and I think other docs in the field, believe that was a mistake. So when we talk diagnosis, we're not just talking about confirming your diagnosis. We're talking about finding what specifically is going on. How would you treat this differently from another case of TOS? So here's two big questions. What do we need to see? And what imaging tests do we have? All right, what do we need to see? Well, the thoracic outlet, as I've demonstrated to you before in these talks, there are muscles, there's fat, there's nerves, the big brachial plexus, there's fibrous bands that show up, there's bone, there's lung. There's also blood vessels, and in those blood vessels, we have different types of blood flow. We can form blood clots. And there are finally dynamic changes. When you move your arms, what happens to your thoracic outlet on each side? So those are things we need to see to be reasonably accurate and helpful diagnosing TOS. And as I said, pointing before, what type of TOS do you have? You've seen this picture if you've seen my talks. I love showing this picture. It's a beautiful pencil drawing done on a computer. You can see the muscles, the nerves of the brachial plexus, the subclavian artery, the subclavian vein, the bones. In between all that is fatty tissue. You see the spine. This is just a reminder, because if you've watched my talks, we've gone over anatomy many times. So let's switch to what imaging tests we have. That's the point of this talk. And here's a list of them. We're going to go through one by one. X-ray. Everybody's seen an X-ray, and with Halloween coming up, we're going to see lots more people walking around like skeletons. This is the first medical X-ray ever made. This is a guy named Conrad Röntgen in 1895. He had a laboratory. He had discovered this strange radiation that seemed to pass through the tissues. And this is Röntgen's wife's hand with her wedding ring on. Now, 1904, this is an early example of an X-ray. You can see cervical ribs if you look closely at the top. Right after Röntgen discovered X-rays, people found that patients with these strange symptoms in the nerves of their arms had an extra rib, a cervical rib, on this new fantastic X-ray. And so they came up with the name Cervical Rib Syndrome. But it's not as simple as all that. Hold on one second. I'm going to actually switch out of this for a second because I've got to show something different. Bear with me. All right, there we go. Here's a picture of Röntgen. That's what I wanted to show before. Remember, 1895, he discovered in this laboratory what X-rays could do, and that's his wife's hand. Now, this is a study from 1904 that I mentioned. On your right side, the patient's left side, you'll see a large cervical rib. It's an extra rib. And this is where people came up with the name Cervical Rib Syndrome. To this day, there are a decent amount of docs out there. When you mention TOS, they think cervical rib. And when you mention cervical rib, they think TOS. Obviously, the disease is a lot more complicated than that. There are lots of patients with cervical ribs who don't have TOS. Here's a modern picture. Again, it's better than the previous one if you look at the quality. That's the previous one. But still, the modern one really just shows bones. Shows a little bit of soft tissue, but it doesn't have great detail separating things out. Now, this is a quiz I give people often. On the left picture, you'll see two cervical ribs. And on the right-sided picture, you'll see two cervical ribs. I dare you to tell me which one of these patients has TOS. And after you do that, I want you to tell me which side they have TOS on. It can't be done. X-rays don't do it. They add very little to the clinical examination. There are patients with cervical ribs that do not have TOS. And there are plenty of patients, the majority of patients, who have TOS, but do not have cervical ribs. So this is kind of a red herring. It may be contributory, but by no means should this be relied upon for any significant value in diagnosing the majority of cases of TOS. Now, here are the advantages of an X-ray. Yes, you can see bones. Yes, they're widely available. You can get them anywhere. You can go to Walgreens probably and buy your own X-ray tube. And they're inexpensive. X-ray disadvantages, they only show two dimensions, front to back, or maybe side to side. So when you have structures overlapping, it's very hard to tell which one is in relation to the other one. The soft tissues, as I mentioned, very limited views, and it does give you a small dose of ionizing radiation, the kind of radiation we like to stay away from unless we really need it. In this case, depending on the body part you do the X-ray on, it can be a low dose or a moderate dose. Let's go on to arteriography. After people discovered this dye that you could inject into blood vessels, this was back in the 1930s or 1920s, they realized you could use X-rays and take pictures of the arteries as the blood flowed through the arteries. Now today, we take one of these. It's called a catheter, very flexible, specialized type of plastic with a soft tip. Can be various shapes to do various tools within the body, various tasks. And you have to start down. The lower left picture says puncture site in the groin area or the wrist. So you have to get inside an artery somewhere. That means taking a needle and going inside a high pressure artery. Once you're inside the artery, under the guidance of X-ray, you keep watching as you move the catheter up the aorta, this big vessel in the middle, towards the heart, in the case of TOS at least. And when the catheter is very close to the heart, here's a picture of a lab, by the way, with a heavy-duty X-ray tube. Now you can see the catheter projecting over the aorta right near the heart. And when it's there, you inject dye. That's the black color in the artery. Now it's denser here. Now you can see the arteries are lit up, and you get a pretty good idea what's happening with the arteries. Now this is valuable for many diagnoses in medicine, but it's been replaced in large part by CT angiography and MR angiography. That's CT scan or MRI scan can do angiography as well. Okay, here's a picture of the artery to the right arm. No compression. This is pretty normal looking. Now here's an example of two pictures on the left and on the right. And you'll see on the left, the artery looks normal. That's with the arm down. This happens to be a baseball pitcher. The picture on the right labeled B, that's with the arm put out to the side. And now you can see that the artery at that white arrow is compressed as it wraps around the head of the upper arm bone, called the humerus. All right, on the left, the arm is down. On the right, the arm is up, and the artery is compressed from outside. This is one type of arterial TOS. You'll also notice that to get the big picture of the artery, you have to kind of erase the bones. So really, you're getting as pure a picture of the artery as you can. But that means you cannot easily assess what are the other structures that are pressing on that artery. Now, some cases it's obvious. You don't really need to see them. But in many cases, because of the complexity of the thoracic outlet, you want to see what exactly is pressing on that artery. So, advantages. Well, it shows arteries with high resolution. It shows blood flow kinetics, meaning how fast does the blood flow through a certain area. You can learn something by watching the blood flow. Is it fast? Is it slow? Is it turbulent? These things are moderately available, not in every place. You can't buy one of these kits at Walgreens, but most big hospitals have someone who can perform angiography. And when I say it allows intervention, many of you may have heard of a balloon angioplasty or a stent placement. Well, these are additional interventions that once you're inside the artery, you can do things to fix those arteries. Now, in TOS, that's not nearly as important as you might think, because usually it's not the artery itself that's a problem. In arterial TOS, it's because there's something outside of the artery that's caused damage. So arterial TOS typically presents with a blood clot or an aneurysm. You want to get that blood clot out, and that's an emergency. But after that, to treat the aneurysm or to treat stenosis or narrowing, you need to also fix what's outside of the artery and compressing it and causing the damage. So the intervention you can do during these procedures is not always useful in TOS patients. And the disadvantages of arteriography, like X-rays, it's only two dimensions. You can't tell which structure is overlapping another, whether it's in front or in back, or how close it is. You can see the vascular structures of the blood vessels, and you can see the bones pretty well. The rest of it, like the soft tissue, is very hard to see. The ionizing radiation is actually a pretty good dose. It's moderate to high doses to get these studies done. So it has to be done by someone who's reasonably quick at doing it and tries to avoid administering too much X-ray radiation. And then because you're administering this contrast, it may affect kidney function. If you have bad kidneys, it's hard to get an angiogram because it's too much stress on the kidneys. Let's switch to venography, which is pictures of the veins. This is great. This is from a doc in Brazil who sent me this great image. You're going to see nothing here, but then gradually you'll see the slow progression of this black dye coming from the veins in the arms towards the chest. And with the arms down, it fills up the veins, not a big deal. With the arms up, look to your left. You're going to see that the blood does not cross into the chest very easily. And it also has a lot of extra small vessels we call collaterals. I'm going to do this again. First, we don't see anything. We see the bones. And now we see coming up the veins this dye that was injected. Okay, I'm going to freeze it. If you look on your left side, the patient's right side, you'll see that there's not really much of this black contrast getting back to the heart. And you'll see lots of extra little vessels. And as you raise the arms, what you'll see is a point of narrowing right there. So your right side, the vein comes into the heart pretty well. On your left side, you can see that there's extrinsic compression of this vein, and there's a blood clot there. Okay, so this is really good for looking at the veins, but you know what? It has the same advantages and disadvantages as arteriogram. It does show the veins with high resolution, and it does show you how fast the blood flows. What are the kinetics? The disadvantages include you only see two dimensions. You can't tell what's in front or back. you're seeing primarily vascular structures, which are the blood vessels, and the bony structures, but not the soft tissues very well. There's a decent amount of ionizing radiation. You want to be careful how long you look at these, because when you take the pictures, it administers X-rays. And because you give contrast, it may affect your kidney function. I'm going to move on to ultrasound now. Ultrasound, and this is one that has obviously added labels so you can see stuff. This is a picture of the anterior and middle scalene muscles and the brachial plexus passing between those muscles. Now, these are all labeled. When you're looking at it real time, it's not so easy to tell them apart. They're all kind of shades of gray, and they can be pretty close or actually wrapped around each other. So ultrasound can show the soft tissues, and it does have the advantage of being able to move the transducer, the thing that records the pictures, into any plane you want. But because of its physics, it's hard to separate out various soft tissues. You also, with ultrasound, cannot see through bone or through gas. So you can't see into the lung, and you can't see between bones. So one of the common sites of compression in TOS is between the collarbone and the rib. And that's a blind spot in TOS. That's not great. Now, look at the image on the left, compare it to the same level on the right. You can see all this color added in. That's blood flow. So ultrasound has a great property of being able to measure blood flow, to look at the waveforms as the blood flow goes by and assess them. Here's an example. On the top left, the image labeled A, that's an example of the subclavian artery with the arms down by the side. And the graph on the right just shows the velocities. Now, image C shows what happens when this particular patient raises their arms 90 degrees. You can see the waveform on the left image, labeled C. It's kind of blunted and slow, and it's not as high as image A, because that artery is partially compressed. And if you look at the graph in image D, you'll see that the velocities are lower, and they're slower to rise, and they don't hit a sharp peak. They come back down kind of slowly. So this is clearly evidence of compression of the subclavian artery. Now, this does not tell us whether the nerves are compressed. Here's another example of it. If you look to the right side where you see these waveforms, the one on the right top is a normal waveform. The one on the right bottom is what happens when the arms are moved, and you see all this fuzzing out. You don't see a really single white line. You see just a broad brush. That's called spectral broadening. It means that there's turbulence in the blood flow. So great, these images show us in real time as you're moving the patient's arm whether the blood vessels are compressed. Okay, that has some value. But you know what? Most cases of TOS are neurogenic, and ultrasound cannot show you one of the most critical points where the brachial plexus is compressed. So, advantages. Definitely has advantages. 3 dimensions, you can move to any plane you want. It's a real-time evaluation. You can watch things happening as you're performing the study. There is no ionizing radiation. It doesn't work on X-rays. That's great. You can do a test as long as you want, and the patient gets no radiation. And there's no contrast that's needed for examination of the thoracic outlet. Now, the disadvantages are it's highly user-dependent. You have a good sonographer or a good doc working on it, that's great. But you know what? There's a broad range of skills in sonographers, especially in thoracic outlet syndrome, where a lot of people, a lot of hospitals, a lot of clinics, they never examine for that. So you got to make sure the person doing the examination has a lot of experience with TOS, and that's not so easy to find. As I mentioned before, ultrasound by its physics is limited by bone or gas, so it has several blind spots in the thoracic outlet. And then when you try to separate out the different soft tissues like the muscles from the nerves, that gets kind of hard to do. As a matter of fact, it's not nearly as good as MRI. We'll see that in a little bit. Let's move on to CAT scans, CT scans. All right, everybody's probably seen pictures of these. You see these on TV all the time. This is actually 2 similar slices in one patient through the middle of the chest. The image on the left, you'll see the lungs are very black, but the heart and the blood vessels are white in the center because we've given contrast. You'll also see around the margin of the chest, around the margin of the lungs actually, at the edges of the black, you'll see those very, very white, bright bones. Those are the ribs. Now the image on the right is where we've manipulated the windows a little bit and we can see the detail in the lung. You'll notice that it's much harder to see the bones separated from the soft tissues or to see the contrast in the heart and blood vessels. So it's really the same image, but you're just kind of changing how the computer presents it on your screen. CT has a lot of value and it can tell bone very cleanly. Really shows bones like this beautifully. This is in the cervical spine. Here's another picture of the cervical spine where we've taken a bunch of those images. This image, we've taken hundreds of those, stacked them together, and now created a new image. That's nice. It really is great for showing fractures and bone detail. And it's also great at showing the contrast in the blood vessels. So this is a CT angiogram. Remember we talked before about a direct angiogram or catheter angiogram. We actually have to puncture an artery and run a plastic catheter and then inject the dye. Well, this CT scan is done with a small cannula or small IV in the crook of your elbow. And you inject the dye, you watch where it flows, and at the right time, you do the CT scan. You'll notice right in the center that curved, bright white thing, that's the aorta coming out of the heart. That's the big artery in the heart. And you'll see two subclavian arteries up around the first rib at the top of the picture. You'll see next to those subclavian arteries the very bright white first rib. So you can see on this how well the vascular structures can be seen with contrast and how all the bones can be seen. And for many docs, that's enough. That's what they need to see. But you'll also notice that the muscles on each side, the grayish things, are very hard to distinguish from one another. And you can't at all tell the nerves from the muscles. So here's another picture, just two pictures from the same area. You'll see again, very bright white bones. That's great. Very bright white arteries because you put contrast in them. But you can't see the muscles from the nerves, so you lose out on the soft tissues. See the blood vessels, but the rest of the soft tissues you can't tell apart. You can do things with CAT scan like make three-dimensional images. This one has a big cervical rib on your right side, the patient's left. And, you know, for many surgeons, seeing in 3D is much easier. Radiologists do this all the time. Surgeons don't. So when we can make 3D models like this, it helps out a lot of people. All right, advantages. CT is widely available, probably almost as widely as X-rays. You can get 3 dimensions in any one plane. And after you acquire the images, you can reconstruct in different planes. It's very useful that way. I said fair to good soft tissue differentiation. You can tell the difference between muscle and fat. You can't tell the difference between nerves and muscle and other soft tissues around that density. That's a big limitation. You can get excellent arteriograms and excellent venograms, but you do have to inject the contrast. And at the bottom, for some applications, you do not need contrast. That's good. Now, disadvantages. As I said, the soft tissue differentiation isn't great, especially for the nerves. And since TOS is a problem with something pressing on the nerves, we need to get that better. The radiation dose is moderate to high. You do require contrast for arteriograms or venograms, and contrast may affect kidney function. That's a problem. Let's go on to MRI. We've already gotten a pretty good idea of all the different things that we do want to see, and I've shown you different imaging studies that show some of those things, but not others. I would like to propose that MRI can show just about everything in the detail we need for patients with TOS. This is just a typical MRI slice. The fat is white, the muscles are dark gray, the brachial plexus on each side is medium gray, and you can separate it. You can see the bones of the first ribs. You can see into the spinal canal. You can see the spinal cord. I can see the thyroid gland. I can see small lymph nodes. It's great at soft tissues. Just another example of MRI. The fat is white or light gray. The muscles are medium to dark gray. The brachial plexus is a lighter gray. Can separate it out beautifully. We can see the bones in this case. We even see subclavian artery and vein without contrast. Now, if we give contrast, on your left side, you'll see a beautiful MR arteriogram. This is with contrast, but the contrast is not nearly as bad for the kidneys. And we don't need to use any X-rays for this. This is done in a magnetic field with no X-rays. And the images are darn nice. If you look on the right side, it's the same patient. We just waited longer, and then we took pictures and have a venogram as well. So we've got soft tissues, we've got bones, we've got arteriogram, we've got venogram. Here's an example of a venogram, and you'll see a very, very narrow, tight space here caused by the rib and the clavicle coming together. You'll also see right after that compression, there's an aneurysm. So clearly MRI angiogram, widely accepted, can do this job. But what you'll also notice in this picture is you don't know what's causing that compression. Everything else is made black so that we get the best arteriogram, okay? What we do at NeoVista is we acquire all the images of everything we need to see at one shot. So I can take this image and say, yes, there's a compression. And I can move to the other images that are all carefully planned, and I can see exactly what structures are pressing on that artery, even if the other images don't show the arteries. Here's a picture you can't get with any other study like a CT or an ultrasound that we showed. This is part of the spinal cord. These are the pieces and components of the brachial plexus on each side. You can see them all beautifully laid out as they come out from the spinal cord and the spinal canal, and they head out into each shoulder. You can take these and you can do all kinds of fun stuff. This is a picture of a brachial plexus, just the right-sided brachial plexus by itself. Okay, you'll also notice on this that everything else besides the nerves is black. You don't see the arteries or the veins, right? Because when you create MRI images, you can play all kinds of tricks to make certain tissues like the nerves show up and other muscles, arteries, veins disappear. Okay? One more picture I'm going to show you. This is the same patient. On the left is a picture with the arms down by their side. You'll see the collarbone and the rib and the brachial plexus looks fine. On the other side, you're going to see the arms up, and you're going to see what happens that the collarbone gets too close to the first rib and it presses on the brachial plexus. You can't see this with any other study. That's really important. So what are MRI advantages? Well, it's widely available. You can get 3 dimensions, again, in any plane. It has excellent soft tissue differentiation. When we want to see the brachial plexus and we want to see what's pressing on it or twisting it or stretching it, we want to see all those soft tissues, which are by far, in my experience and my practice, the most common cause of TOS. The other most common cause is going to be compression between the rib and the collarbone. That's what we looked at here. And this is the study to see it. I'm going to get rid of these arrows. Bear with me for a second. Mac won't let me separate this out and go fast. One more advantage of MRI, you can get excellent arteriograms and venograms, a lot like CAT scan can. Now, more advantages. You don't need contrast for many applications. And when you do give contrast, it is not likely to affect kidney function, not nearly the same risk as CAT scan contrast. Okay, remember, you don't need radiation for an MRI. You do for CAT scan. Now, the disadvantages. To get the optimum technique, you need significant radiologist input. Your radiologist needs to work with your technologist, and it takes a while to develop the right kind of protocol. That's where we've spent so much time. You can get a subclavian artery artifact that looks like compression, but it isn't. That's where one of our patents has been applied to get rid of that artifact. And MRI can have more motion artifact than other studies. If any of you have had an MRI, you know that the tech asks you to stay still for a while, 3, 4, 5 minutes. That's a lot longer than a CAT scan or an X-ray. So sometimes patients have to move a little bit, and so we can get that artifact. A couple more disadvantages. Some patients do get claustrophobic. Most patients can get through a scan. And then there are certain contraindications, like patients with aneurysm clips that are older, some metallic foreign bodies. Some patients can't get an MRI. So we always say here, don't guess with TOS. Choose NeoVista. We're proud of what we do with our MRI. We think it is the best modality for diagnosing TOS. If I had to pick any weakness, I'd say we don't see bone detail quite as well as a CAT scan might. But since bones are much less likely to be the cause of TOS in the areas where we don't see it well, I think that that's a really minor limitation. All right? Don't guess with TOS. Don't let your doctor say, yeah, you probably have TOS. Come and see us, and we'll help you get the real diagnosis. And now I'm going to exit this and stop sharing my screen. And I am going to take questions. And hopefully we have some good questions here. All right. Janine in Northern California says, my doctor had me do an ultrasound for TOS before considering any other imaging. Is that normal? Now, this depends on the doc. We do know, you probably all know, that there are many different specialists that treat TOS patients. TOS has never been a field that's been owned by one specialty. So you may have a doc who's got a preference for one type of imaging. I know at Stanford, they published a paper a few years ago with a team that said, we do ultrasound on everybody. And when you read the paper that they wrote, they're basically looking at the blood vessels. You may recall when I showed the pictures of ultrasound and blood vessels, I said it works great. You can really see compression, but you can't see whether the brachial plexus is compressed. And this is critical. From my MRI studies, I know there are patients with brachial plexus compression. They have no arterial compression, and vice versa. So compression of the artery is something that Adson did in the 1920s. His test, Adson's test, is meant to show whether the artery is compressed. He assumed in the 1920s that if he could show compression of the artery, he could assume compression of the brachial plexus. But Adson didn't have CAT scans, he didn't have MRIs. So that was the best anybody could do, and it was a clever test. We know now that Adson's test missed a lot of cases, and it overcalls cases. Adson's test, or an ultrasound showing the equivalent of Adson's test, does not show whether the brachial plexus is compressed, and it does not show the fibrous bands, the extra muscles, the intertwining of the muscles and the brachial plexus. Those are critical things to know before you try to treat TOS. So ultrasound's a starting point, and at least, Janine, if your doc thought about TOS, that's a good start. We hope that all of our patients get a doc early on who recognizes TOS and at least proposes some kind of imaging test. Thank you for the question. All right, hey, Muddin' Truckin' Hunting's back. All right. I have heard that posture during imaging matters, such as sitting up versus laying down. What do you think of this? What I think is that's a great question. I actually was just looking at a paper today. When they did direct catheter angiography in the 1960s, several people published papers showing that laying down patients with this contrast going through a catheter versus sitting up patients getting the same test, that there was more arterial compression when the patients were sitting up. And I think it should be easy to imagine that the weight of the shoulders when you're laying flat on an MRI table or a CAT scan table is very minimal. But when you stand up and you've got the weight of the shoulders and the arms pulling things down, including the collarbone, that you would increase that amount of compression. So whatever we see on MRI, I assume in normal life where a patient is sitting or standing, that compression is actually going to be worse. We're thinking of doing a study to try to prove this, but the question is excellent. I think it's been proven on previous arteriograms. Of course, they couldn't see the brachial plexus with the technology at the time, but I think it's absolutely true. Thank you for the good question. All righty. You mentioned contrast or something like that helps the MRI. Can you explain? And that's John in Alabama. Thank you, John. So we give contrast on almost all of our MRIs. We do it for a number of technical reasons that help certain things stand out, but in particular, to get the MR angiogram pictures that you saw, those nice, beautiful pictures of the MR angiogram that shows just the white arteries. We need the contrast to get the best quality images. And then we can also get pictures of the veins when that contrast flows through the arms and comes back towards the heart. So we can get angiograms and venograms. And I think that's the most important reason that we do give the contrast. Contrast for MRI is much less likely to be harmful to the kidneys. There's much less likely chance of a serious allergic reaction to it. And it's used widely throughout the world, probably 1 million times every day. Thanks, John, for the question. Brad in Eureka. I've never been to Eureka, but I heard it's nice there. He asked, I heard you mention that your specialty MRI has multiple patents. Does that really matter? Well, that's a question I've thought about several times. I think our work to get the patent and our work leading up to the patent was important because we figured out a lot of things in terms of how to make the images better. It is intellectual property. You know, it's hard to get a patent. It was a lot of hours and a lot of money for lawyers. And the first one we got, we learned a lot through that. But I think in the performance of what we do, I think there's much more importance in what my team does, how we get patients to understand what TOS is, how we do educational efforts like this, how we do awareness. We're always trying to raise the level of awareness for patients around the country as well as doctors. My experience of reading these MRIs, because I've read so many of them, because I'm always talking to doctors around the country and picking their brains, because I observe surgeries, because I'm kind of obsessed by this and trying to do better at it. I think those factors help us be unique in our skill set, our combined skill set as a team, and as part of the community where if we don't know something, we can get you to somebody who does know something. So I'm really proud of our connections with people in both coasts and people in the middle of the country, Northern California, Southern California, and people around the world. You remember I showed you the video of the venogram. That's from a doc in Brazil. Should be able to hear me now. Hello, hello, hello. Let's make sure you can hear me. All righty. Very good. Sorry for the audio interruption. Let's see if I can go back to the question that we had, and that was about the patents. I just want to remind people that I think our team, everybody on our team is trained to help patients understand TOS, our efforts to raise awareness around the country, our efforts to build connections around the country with doctors and patients, and our willingness to help people get to the right resource, whether it's our scan or not, is what makes us different more than just the patents that we have. So thank you for the question, Brad. We have a question from Stephen Adams. Hi, Stephen. How are you? All right. Stephen is a regular participant. He's always asking good questions. So he says, the previous speaker, Dr. Garagoslu, argued that in many cases, a culprit of TOS relates to abnormal bone formation on the first rib at a joint. Can this be imaged, and if so, how? Thanks, Steve. Dr. Garagoslu talks about a prominent scalene tubercle, just medical words, but the anterior scalene comes down and it inserts on the first rib. And in a subset of patients, that spot where it inserts on the first rib gets bigger. It grows a bony bump that rises up above the first rib. And that can be right in the spot where the subclavian vein has to cross over the rib and underneath the collarbone. There's also a tendon there, the origin tendon of the subclavius muscle. So it's a complex, tight little area. And one of the things that takes up space is that scalene tubercle. It can be seen on CAT scans. It can be seen on MRIs if you look for it. In particular, when we do our study, when patients raise their arms for that part of our test, we can see not just the bone, not just the scalene muscle, not just the tendon of the subclavius, but we can actually see what effect it has on that vein going through that area. And if the vein is compressed, we can see in the arms whether the blood flow coming from the arm has been slowed down by that compression of the vein. So yes, you can see it in imaging. It's called the scalene tubercle. Yes, there are some patients who have this, and it's a perfect example of why some patients with quote unquote TOS have a different pathology. It's not always compression between the collarbone and the rib that gets the brachial plexus. It's not always a scalene minimus muscle. Sometimes it's a scalene tubercle. It's a different subset of patients, and they probably need to be treated a different way than patients with those other problems. So that's a multi-layer question, and Stephen, I appreciate you asking that. Thank you. All right. Jenna or Gina in Sacramento. I'm not sure how to pronounce your name. Thank you for a question. I watched one of the earlier talks with Dr. Jenkins, and he seemed to be saying that TOS is very hard to diagnose for even the best doctors. Are you saying that MRI is the answer? Well, putting me on the spot, what we do and what we've done for 20 years, is that important? How do I answer this question humbly? So again, I think our team is really great. We don't just diagnose TOS with MRI. I'll get to that more detailed question in a second. But I think the whole team and how we approach TOS, that patients need help and we need to diagnose them more quickly. So not only do we help the patients who contact us, but we also try to raise awareness so that more people actually think of TOS. You know, you get pain in your neck and your arms, and it goes down to your fingers, and you've had a car accident or a bike accident. Nobody knows to look up thoracic outlet syndrome on Google. If you go search neck pain or arm pain, there's, 20 million entries. How do you know what to look for? So doctors should be able to screen this out, but doctors don't get a lot of training of TOS in medical school. I don't remember a single class or a single lecture that even contained something about TOS. So my knowledge of it was very peripheral, and it was only accidental that I got involved enough to learn more about it. I'm glad that I did. What we know now is there is no gold standard for the diagnosis of TOS. There is no one test that is 100% or 90%. It's right now based on a clinical evaluation. If you read the leaders in the field, they'll often say, well, it's non-specific and it's this and it's that, but when I see it, I know it. And now I'm publishing a paper with 100 TOS patients. But you know what? Those 100 patients have TOS because that doc says they do. That's not a gold standard. A gold standard is an objective, repeatable test that we all agree on. And then when you come up with another test like an ultrasound or an MRI, then you compare it to that gold standard and say, how accurate are you? Now, we don't have that. But what we do know is there are nerve entrapments throughout the body, like carpal tunnel syndrome and cubital tunnel syndrome and tarsal tunnel syndrome. There's all kinds of these. And they're almost always diagnosed because a doc suspects the problem, sends the patient for an MRI, and the MRI shows the nerves that are involved and anything around the nerves that could be compressing or stretching or squeezing or affecting those nerves. And that combination is widely accepted in medicine as being diagnostic of that particular entrapment neuropathy. So TOS is the same thing. It's an entrapment neuropathy. The nerves themselves start out normal. They get compressed or stretched by any of a number of mechanisms. And just like every other entrapment neuropathy, cubital tunnel syndrome, carpal tunnel syndrome, we apply MRI, we show the nerves, we show everything around the nerves. TOS, it's more complex because you can move your arms like you can't move other parts of your body, and that makes it more complex. Also, in the neck, there's a ton of complexity, and every patient is different. So we get a lot of anatomic variation between one patient and another. So it's a complex disease to diagnose, but we're learning to do that. And Dr. Jenkins is right. Of course he's right. The guy is brilliant. I love listening to him. It is hard to diagnose. There is no 100% test. We believe that our combination of a good clinical diagnosis and our MRI is as close as you can get to that 100%. And we are always learning and always getting better because we're so obsessed with this. So I hope that answers your question. And if it doesn't, please ask for further details. Jimmy in Chicago. My sister has TOS. She's a teen soccer player, and she swears it started when she fell and broke her wrist. Is that possible? Jimmy, that's a good question because the wrist seems different and distant to the thoracic outlet. But it turns out we see a decent amount of these histories where patients fall and they use their upper extremity to break their fall. Young athletes get TOS a surprising amount of time. And so what we believe is that the trauma gets spread throughout the upper extremity. Your arm doesn't exist in isolation. And in some patients, you're just in the wrong position when you fall. And all the muscles of your neck and shoulder and elbow and wrist, they all work together to brace your fall. And the shock may be absorbed by different sets of those muscles. So if a patient has a fall and they have TOS, it's a very credible history. It's just not a guarantee of anything. You can't say that person fell, I saw them fall. What are the odds that they have TOS? It doesn't depend on the fall. It depends on the results of the fall. So yeah, young athletes get TOS and they fall on a soccer field or excessive overuse of the arms overhead, like tennis serving, volleyball, swimming. Those patients are predisposed, especially young collegiate athletes, high school athletes, to getting TOS. And we hope more docs are aware of this so those patients get recognized sooner and get to diagnosis and treatment sooner, because that's really, in our experience, without any numbers, it seems to be the way that patients recover from TOS the best. Fast diagnosis, good treatment, the right kind of treatment without delays. Thanks for the question. Jason in Florida, currently in Florida. Jason says, I'm from Canada and the care options up there for TOS are poor. Do you know if there are better TOS options in other countries? Thanks, Jason. I hope it hasn't delayed your treatment too much. We hear this from a decent amount of people from Canada. It's a different healthcare system. And from my reading, in a lot of ways, it's good. And people are happy with basic care, generic care, really seeing most things. But I don't live in Canada, and so I can't tell you my personal opinion. What I do, if I have to take a guess at it, is that systems like this are designed for, the 95% of cases, the 95% of patients. It gets a lot harder if you try to cover that last 5%, which is oddball diseases. People consider TOS oddball. They think it's really rare, even though I don't think that's true. Because there's no gold standard, we don't have any good records of how many people get TOS. So because it's relegated to this rare category, we find that some other countries, as well as Canada, they're just not prepared to handle something this challenging and different. So in my experience, Jason, we've seen patients having to fight their doc to even consider TOS. If they do break through and the doc says it could be TOS, they often recommend an angiogram or a CT angiogram. But in my opinion, that really misses a lot of things. Remember that 95% of cases of TOS are neurogenic. So an angiogram may be completely normal and it won't rule out neurogenic TOS. But in fact, some of the patients we've dealt with from Canada have gone through that terrible cycle of really suffering what sounds like neurogenic TOS. We've seen some of them and they do have neurogenic TOS, but their doc says your CT angiogram is negative, you can't have TOS. Now that's not true. I don't expect other docs to know TOS as well as me. They know a lot of other things way better than I do. I happen to be into TOS and it's had its rewards because I help a lot of people. It feels good. But I would hope that a good doc would say, look, the angiogram is negative. Let me find somebody else who knows more, or let me go do some reading. And I'm not sure that always happens, especially when docs are very busy or they're very subspecialized. So a vascular surgeon, he or she will see, dozens of arteriograms and venograms in a week. And that's what they specialized in. They look at the blood vessels, they know the blood vessels, they know the bones around them, but they don't know all the complexity of TOS because it's just not in their purview. And that's one of the problems. TOS has never been owned by one field. And so you don't get docs who see the holistic picture, all the soft tissues, all the changes in the shoulders. I spoke a week and a half ago to an experienced physical therapist in Marin County, that's north of San Francisco. And she takes care of a lot of professional athletes locally, the Major League Baseball team for one. And we talked in great depth about what happens to the rotator cuff and the thoracic outlet and the muscles around the shoulder. And she had an amazing amount of knowledge that no doctor I know has, including me. I learned a lot from her, and we have another conversation set up. So this disease really requires an extra sensory perception of all these crazy things that go on. And there are some experts out there who just know these amazing things. So when you have a doc in Canada who's specialized in vascular surgery, they may just look at arteriograms, and that will limit the diagnosis of neurogenic TOS. Now, for a patient to come to the US, I don't know how hard that is to have your Canadian healthcare pay for some of that cost or all of that cost. Some of the patients we've had have had to pay for it out of their own pocket. I think at the least one option that's made better now is that some docs are able to do teleconsults. I'm sorry for the length of this answer, by the way, but it's a really good question. There are docs who will do teleconsults. So you could be in Canada, you can arrange with one of these docs to interview you by phone, by video chat. They can't do a physical exam for obvious reasons, but they can get a lot of history out of the way. And if it's a doc who really knows TOS, then they can get a pretty good idea, I think, of whether you need further testing or not. So you can contact us. Our website, of course, is tosmri.com, and we've steered several people to connections with TOS specialists that we know who will do teleconsults. And I think that's probably the best starting option before you spend a lot of money or time getting one of our scans. Talk with a doc who's experienced and let them get that first 80% out of the way by just talking to you. So I hope that helps with your question. Thank you very much, Jason. And what about, Jason asks again, what about other countries outside of North America? I travel to Europe often. So I right now don't know a lot of people in Europe. I know a few people, but I would say, you know, I'm happy to talk to anybody. Sometimes patients contact me and they have a doc that I've never met before. And you know what? If I'm connected to them, I might learn a lot like I did from this physical therapist. So it never hurts me to have a phone call with a doc, and maybe I can share with them some of what we do. So I don't know docs in Europe that I can recommend people to. Mostly it's people in this country I know. But, you know, I'd say some of the good signs, the green flags are, does the doc have an open mind? Does he or she know something about TOS? And is he or she willing to read more and learn more about TOS? For instance, if you offer, hey, I've got this doc in San Francisco, would you mind speaking with him? Some of those docs will say, I don't need to. Well, that's not a green flag. But other ones will say, sure, I'll connect. And that's a good sign. So I hope that helps. Stephen Adams again. Hi, Steve. Dr. Gargoslu also argued that compression of the veins could bother the nerves. How common would you say this view is among TOS physicians, and what is your view? So, Steve, you always have these good multi-layered questions. So most docs are going to look at this as the classic TOS, the ones that do treat TOS right now. Let's say vascular surgeons. I think of any field, they're the most involved in TOS. But of course, there are other docs all around the country of different specialties that handle TOS as well. But vascular surgeons seem to be politically in the center of this. And they publish more and they see more of it. They get referred more of these patients. They probably talk directly about the compressive effects of the rib and the clavicle. And they look at the arteries and the veins to see damage there. But there's another group of docs who are progressive, some of the docs that I work with in various parts of the country, who are really trying to push ahead and figure out, why do we only have this success rate? It's not perfect. It's not really close to perfect. I'm going to tell a little story on the side. I may have told before, it's been in some of our other videos. It's about appendicitis. Appendicitis used to be a potentially fatal disease. And for decades, there were people who didn't even believe that human beings had appendices. But when they finally agreed on that, they wouldn't agree that the appendix getting inflamed or infected was the cause of this disease in the right lower quadrant. It took quite a long bit of time, and it took a guy named Fitzhugh at Harvard, had like 250 cases he collected that showed cadavers who had died from this, and he had pathology. And then surgeons slowly did surgery on it, but in the 1820s, 1850s, surgery wasn't as safe as now. So eventually over time, people figured out appendicitis. But then even into the modern era, before 1995, let's say, the positive rate and negative rate, the false positive and false negative rate for appendicitis, meaning when a doc examines you, did he or she say you don't have appendicitis when you really did? Those were about 15% of cases. That's pretty high. And the docs who had a false positive that said, I'm going to operate for appendicitis, but in fact it wasn't appendicitis, and that was about 15%. So we had 15% false positive and false negative. Well, if you look at TOS now, after surgery, within a few months, about 15% of patients are not better, or maybe worse. 85% of patients are moderately to significantly better, but 15% are not. And if you go 2 years out and you follow up these patients, about 30% of patients are not better, or they are worse. So those aren't great numbers. And I'll also point out that the reason the diagnosis of appendicitis got better is because one guy, also at Harvard, he decided to do CAT scans on everybody, and no one had really applied CAT scan to appendicitis before that. Well, finally, when he proved his point that CAT scans can really show when you have appendicitis, he had made a huge difference, because we found out that the appendix can be located all over the abdomen. Trying to press the right lower quadrant, the appendix may not be there. I remember years ago in medical school, when I went to medical school, this is when we had candles in the operating room. I exaggerate a little. But there was a case that showed up in the middle of the night, and I was on call to work with the surgeon. And I remember the patient having pain in the left lower quadrant. And, I was thinking, it was diverticulitis, but it turned out it was appendicitis. The appendix was not in the usual place. Well, it's the same thing with TOS. There's lots of anatomic variation. And our rate of success, as I mentioned the numbers before, is not great. So we can do better at TOS. I make those points because we have progressive people like Dr. Garagoslu and other docs around the country. And we believe that compression of the veins, through some of the data in the literature, compression of the veins leads to a chronic congestion or fluid that builds up in the muscles. And this fluid can clearly affect the nerves. So if there's severe intermittent vein compression, we believe that over time that helps contribute to whatever compression of the nerves is occurring. If something is pressing on the nerves, that we can see directly on an MRI, but compression of the veins probably makes that worse or may initiate the process in some patients. Now, we don't know the numbers. We haven't done research on this to prove it yet. It will be challenging, but a lot of docs in the field just see the direct compression effects. I think, my opinion, and it's supported by some of the literature, is that there is evidence out there that venous compression by itself can either cause or contribute to those other findings of compression or stretching. And therefore, we need to always be looking at the veins. That's what we do with our MRI. No matter what we see on the brachial plexus, we always describe the veins. And those need to be treated if there's the clinical finding of TOS. Okay, that's a real can of worms. And I'm glad to discuss it, but you better sit down with a bag of popcorn because it can go on for hours. So thanks to you. That's a good question. All right. Well, we want to thank everybody. No more questions and answers right now. Again, we want to point out that toseducation.org, toseducation.org has sponsored this talk. They're great for finding new videos. We also have the videos on our website, tosmri.com. We have another talk coming up in 2 weeks. We hope you'll keep up on our schedule. We also hope that you will follow us on social media. The next talk is with one of our favorite viewer favorites, Steve Talikowski, physical therapist who does the Edgelow technique. And as you can see at the bottom, he says, regaining control with physical therapy. This is a really neat talk. Steve is a great speaker. He knows a ton. We want to remind people to follow us on social media. We are TOS MRI on Instagram, Facebook, YouTube, where you're watching. And if you have questions, reach out to us through TOS MRI website. Thank you again for attending. We'll look forward to seeing you on our next talk. Again, this is Dr. Scott Werden, the TOS guy, and I will see you next time.